Diabetes mellitus in children. DM type I. Alanariga. KHNMU. Diabetes mellitus. DM is a syndrome of disturbed energy metabolism caused by deficiency of INS secretion or INS action at the cellular level that results in altered fuel homeostasis affecting carbohydrate, protein, and fat. Every 10 seconds one patient die from DM. World statistics. 246.000.000 patients with DM in the world were reiterated at 2006 years. 380.000.000 prognosis for 2025 years. Every 10 seconds one patient die from DM. World statistics. Every years the DM type I occurs in 70,000 children. Eurodib, every year increasing DM type I in adults in 3% and in 4.8% in children. Mortality from DM type I. Decrease on the 40%. Historical data. Increasing of the urination was described 1,500 years BC at Egypt. Fisk clinical description of the DM by cells, 30 to 50 years Anno Domini. The term diabio, passing through, 30 to 90 years Anno Domini. 1,600 years, the term mellitus, lot, honey due to sweet urine taste. Historical data, seed. 1,674 years Thomas Willis, Oxford, supposed that the sugar passed to urine from blood. 1841 to 1848 years Stromer and Felling, methodic of the definition of blood sugar by copper oxide. 1796 Rallo at first proposed to restrict the carbohydrate intake to patients with DM. Historical data, seed. 1813 to 1878 years Claude Bernard described the pathogenesis of hyperglycemia. 1869 years medical student Paul Langerhans discovered the cell's congestion in pancreas. 1874 years Kussmaul discovered ketons, aceton, described specific type of breathing. Historical data, seed. 1989 years Mering and Minkowski established that the dogs with pancreectomy develops hyperglycemia and further death. 1902 years Opie, described the degeneration of the Langerhans islet. 1907 years Lane Bursley, Chicago, discovered pancreatic cells type A and type B. Historical data, seed. 1955 years Sanger, Cambridge, discovery amino acid structure and molecular of INS. Peptide is the predecessor of INS. 1969 years Steiner, invented biosynthesis of the C-peptide. 1973 years monocomponent, INS was synthesized. Etiologic classification of DM. I-type IDM, beta cell destruction, usually leading to absolute INS deficiency. 2. Type 2 DM, may rank from predominantly INS resistance with relative INS deficiency to a predominantly receptor defect with INS resistance. Etiologic classification of DM, seed 3. Other specific types. Monogenic DM. Exocrine pathology of pancreas. Endocrine diseases. Drugs. Genetic syndromes such as Down, Turner etc. The onset DM type I occurs predominantly in childhood, with median age of 7 to 15 years, but it may present at any age. DM type I. DM type I is characterized by autoimmune destruction of pancreatic beta cells. DM type I. Beta cells destruction may be due to drugs, viruses, mitochondrial defects, ionizing radiation, etc. DMI type. Genetic susceptibility to type I DM is controlled by alleles of the major histocompatibility complex class II genes expressing human leukocyte antigens, HLA, that associated with antibodies to glutamatic acid decarboxylase. DMI type is associated with other autoimmune diseases such as thyroiditis, celiac disease, multiple sclerosis, Addison disease, and etc. Manifestation of the DM if the 80 to 90% beta cells were destructed. DM2 type resistant to INS. Etiologic classification of DM, C3. Other specific types. Genetic defects of beta cell function: chromosome 12, HNF1, MODY3. Chromosome 7, glucokinase, MODY2. Chromosome 20, HNF4, MODY1. Mitochondrial DNA. MODY maturity onset diabetes of the young: HNF hepatocyte nuclear factor gene mutation. Etiologic classification of DM, C3. Other specific types. Genetic defects in INS action. Type A INS resistance. Leprechaunism. Rabson-Mendenhall syndrome. Lipotropic diabetes. Lorentz syndrome. Type A adolescence INS resistance in absence of obesity. Acanthosis nigricans. Androgen excess and hypertrichosis. Gene-involved insulin receptor. Recessive. Leprechaunism congenital abnormal faces large genitalia. SGA and growth retardation. Rarely survive infancy. Acanthosis nigricans. Gene-involved insulin receptor and GH resistance. Recessive. Leprechaunism. Rabson-Mendenhall congenital extreme growth retardation. Abnormal dentition. Acanthosis nigricans. Androgen excess and hypertrichosis. Gene-involved insulin receptor. Recessive. Lipodystrophy Lorentz syndrome. Congenital or adolescence. Loss of subcutaneous fat, partial or total. Acanthosis nigricans. Androgen excess and hypertrichosis. Gene-involved total, cypin and AGPAC2, recessive, partial, lamin AC and PARG, dominant. The key feature of all insulin resistance syndromes are acanthosis nigricans, androgen excess and massively raised insulin concentrations in the absence of obesity. Maternal transmission of mutated or deleted mitochondrial DNA, MTNA, and the mitochondrial TRNA, LUR, gene, B, can result in maternally inherited diabetes. Melitus syndrome. Mitochondrial myopathy. Encephalopathy. Lactic acidosis. Stroke-like syndrome. Mitochondrial diabetes is commonly associated with sensory neural deafness and short stature. The diabetes is characterized by progressive non-autoimmune beta cell failure and may progress to needing insulin treatment rapidly. Etiologic classification of DM, C3. Other specific types. Diseases of the exocrine pancreas. Pancreatitis. Trauma, pancreatomy. Neoplasia. Cystic fibrosis. Hemochromatosis. Fibrocalculus pancreatopathy. Pancreatic resection. Etiologic classification of DM, C3. Other specific types. Endocrinopathies. Acromegaly. Cushing disease. Glucagonoma. Pheochromocytoma. Hyperthyroidism. Somatostatinoma. Aldosteronoma. Etiologic classification of DM, C3. Other specific types. Infections. Congenital rubella. Cytomegalovirus. Hemolytic uremic syndrome. Etiologic classification of DM, C3. Other specific types. Genetic syndromes. Down syndrome. Klinefelter syndrome. Wolfram syndrome. Friedreich ataxia. Huntington chorea. Lawrence-Moon and Bardet-Biedl syndrome. Myotonic dystrophy. Porphyria. Prader-Willi syndrome, Wolfram syndrome, de mode. DI diabetes insipidus. DM diabetes mellitus. OA optical atrophy. D deafness? Prader-Willi syndrome. Etiologic classification of DM, C3. Other specific types. Gestational DM. Neonatal DM. Neonatal diabetes. There is good evidence that diabetes diagnosed in the first 6 months is not type I DM, as neither autoantibodies nor an excess of high type I HLA susceptibility are found in those patients. Neonatal diabetes is insulin-requiring diabetes, which is usually diagnosed in the first 3 months of life. Neonatal diabetes. Clinically, 2 subgroups were recognized: transient neonatal diabetes mellitus, TNDM, and permanent neonatal diabetes mellitus, PNDM. Transient neonatal diabetes. Anomalies on 6q24 locus. DM associated within the first week and resolves around 12 weeks. 50% of cases DM will reoccur during the pediatric age range. Macroglycemia in 23%. Initial glucose values can be very high, range 1257 millimoles/L, and so insulin is used initially, although the dose can rapidly be reduced. The response to oral treatments such as sulfonylureas or metformin is uncertain. Permanent neonatal diabetes. KER6.2 mutations. Only 10% have a remitting form of DM that may later relapse. Most patients have isolated DM. 20% have developmental delay of motor and social function and generalized epilepsy, so-called Dense syndrome, developmental delay, epilepsy, and neonatal diabetes. Patients have all the clinical features of insulin dependency, do not have detectable C-peptide. It has been shown that these patients cannot be successfully treated with oral sulfonylureas. Etiologic classification of DM, C3. Other specific types. Drug or chemical induced. Pentamidine, nicotinic acid. Glucocorticoids. Thyroid hormone. Sharp acetrenergic agonists. Thiazides. Beta interferon and others. Insulin. INS is synthesized on the ribosomes of pancreatic islet beta cells and is released into the circulation as a molecule comprised of 2 separate straight polypeptide chains linked by disulfide bridges between and within these chains. INS is the major anabolic hormone of the body. INS action is on target cells in tissues such as liver, adipocytes, and muscle. Metabolic events during the fed and fasted states: liver. High INS, fed, and low INS, fasted state. Glucose uptake, glucose production. Glycogen synthesis, glycogenolysis. Absent gluconeogenesis, present G-cis. Lipogenesis, absent L-cis. Absent ketogenesis, ketogenesis. Metabolic events during the fed and fasted states: muscle. High INS, fed, and low INS, fasted state. Glucose uptake, absent glucose uptake. Glucose oxidation, fatty acid ketooxidation. Glycogen synthesis, glycogenolysis. Protein synthesis, proteolysis, and amino acid release. Metabolic events during the fed and fasted states: adipose tissue. High INS, fed, and low INS, fasted state. Glucose uptake, absent glucose uptake. Lipid synthesis, lipolysis, and fatty acid release. Triglyceride uptake, absent triglyceride uptake. Pathophysiology of DM type I. Progressive destruction of beta cells leads to progressively more severe INS deficiency with involving classical stress hormones, epinephrine, cortisol, growth hormone, and glucagon, so-called counter-regulatory hormones. INS deficiency, acting in concert with the excessive concentration of epinephrine, cortisol, growth hormone, and glucagon, will result in unrestrained glucose production while glucose utilization is impaired, so that hyperglycemia develops. INS deficiency in elevating counter-regulatory hormones leads to lipolysis and impaired lipid synthesis and elevation in plasma total lipids, cholesterol, triglycerides, and free fatty acids. The hormonal interplay of INS deficiency and glucagon excess shunts the free fatty acids to ketone body formation. Acetone, acetoacetate, beta-oxoacid. Accumulation of ketoacids results in metabolic acidosis and the compensatory rapid deep breathing, which is an attempt to excrete excess CO2, co-smalls respiration. Acetone, formed by non-enzymatic conversion of acetoacetate, is responsible for the characteristic fruity odor of the breath. Ketones are readily excreted in the urine in association with cations, further compounding losses of water and electrolytes, dehydration. With progressive dehydration, acidosis, hyperosmolality, and diminished cerebral oxygen utilization, consciousness becomes impaired and ultimately results in coma. DM. The loss of weight is on the basis of the catabolic state and urinary losses of calories due to polyuria. The no effective calories balance lead to the hunger and polyphagia. Despite the increased food intake, calories cannot be utilized, and weight loss occurs. DM. Glucosuria results when the renal threshold of 160 ml/dl, greater than 8.88 mmol/L, is exceeded. The resultant osmotic diuresis produces polyuria, dehydration, an increase in osmolality, and compensatory polydipsia, DM. Pyogenic skin infection are most uncommon as a presenting complaint, although vaginitis in teenage girls may be the presenting feature. Clinical presentation. About 30% of patients initially present with frank diabetic ketoacidosis. Air hunger. Co-smalls respiration. Acetone on the breath. Obtundation of consciousness or coma. Vomiting. Dehydration. Hyperglycemia. Hyperglycemia. Clinical presentation. Polyuria. Polydipsia. Polyphagia. Weight loss. Lethargy. Weakness. These symptoms may be present for days to weeks, particularities DM in infants. Lability of the water and mineral metabolism. Stopping or lost body weight. Appetite increase or normal. Thirst, active sucking, particularities DM in infants. Starch napkins or sticky stains due to glucosuria. Dry skin, turgor, skin infection. 2 types of DM manifestation in infants. First, acute onset, severe dehydration, intoxication, vomiting, coma as a toxico-infection shock. Second, dystrophy develops gradually, infection diseases connect. Ketonuria is absent to formold due to liver immaturity. Diagnosis of DM and B. Additional, or absence of C-peptide. Clinical presentation and paraclinic, hyperglycemia, glucosuria, ketonuria. Additional, or absence of C-peptide. Glycolized HB, HbAIC. Fructosamine. Presence of the antibodies to sharp S cells, INS and to different glutamate decarboxylase isoforms. Criteria of DM compensation. The aim of treatment, quality of life. The adequate growth and development of child. Active social position in life and society. Decreasing acute complication and prolonged late complications of DM. Normal life duration. Criteria of DM compensation, SEED, in childhood. Glucose level fasting 4 to 8 mmol/L. Glucose after feeding 10 to 11 mmol/L, 3.3 to 8.3 mmol/L, less than renal threshold. Night glucose level 6 to 8 mmol/L. Episodes of hypoglycemia are absent. Glucose absent in urine. Criteria of DM compensation, SEED. Normal lipid, protein and mineral metabolism. HbAIC, %, 5 to 7. Cholesterol mol/L, less than 5.2. Triglycerides mol/L, less than 1.7. Differential diagnosis. Diabetes insipidus. appendicitis, Fanconi syndrome, diabetes mellitus type 2. Factors influencing vasopressin secretion: increased secretion, hypovolemia, hyperosmolality, upright position, central hyperthermia, stress and anxiety, cerebral disease, chest disease, malignancies, drugs, carbamazepine, clofenac, nicotine, angiotensin II, cholinergic drugs, morphine, barbiturates. Factors influencing vasopressin secretion: decreased secretion, hypervolemia, hyperosmolality, recumbent position, central hyperthermia, diabetes insipidus, drugs and alcohol, dilantin, anticholinergic agents, polyuric conditions mimicking vasopressin deficiency, physiologic suppression of vasopressin secretion, psychogenic polydipsia, organic polydipsia, hypothalamic disease, drug-induced polydipsia, thioridazine, tricyclics, polyuric conditions mimicking vasopressin deficiency, reduced renal responsiveness to vasopressin, genetic, nephrogenic diabetes insipidus, medullary cystic disease, pharmacologic, lithium, demeclocycline, pentherine, diuretics, osmotic diuresis, diabetes mellitus, reduced nephron population, electrolyte disturbance, hypercalcemia, hypokalemia, renal disease, post-obstructive diuresis, renal tubular acidosis, pyelonephritis, papillary necrosis, sickle cell disease, hemodynamic, hyperthyroidism, diabetic ketoacidosis, hyperglycemia, catonemia, acidosis, pH less than or equal to 7.3 and bicarbonate less than 15 MEq/L, glucosuria, ketonuria. Complications of DM, acute ketoacidosis, ketoacidotic coma, dehydration, non-ketotic hyperosmolar coma, hypoglycemia, hypoglycemic coma, lactoacidotic coma. Complications of DM: Chamad phenomenon, Dawn phenomenon, brittle diabetes. Complications of DM, long-term: diabetic retinopathy, diabetic nephropathy, angiopathy of lower extremities, diabetic neuropathy, peripheral, central, autonomic. Complications of DM, long-term: Moriarty syndrome, Neubauer syndrome, syndrome of limited joint mobility, hairopathy, skin pathology, lipoid necrobiosis, lipodystrophy, paronychia and etc. Lipoid necrosis, lipoid necrobiosis, lipoid necrobiosis.